we witnessed, or we came upon a person that was struck as a pedestrian by a vehicle. And as we were coming up onto that scene, there was a bunch of us in the vehicle. There was a pickup truck that pulled out, and two people got out dressed in kind of a Red Cross type of, kind of a visibility jacket or whatever. Picked up the person off the ground by the arms and legs, hauled him into the back of the pickup truck, then both proceeded to jump back in the cab of the pickup truck and drive off. That was their version of 911.
Hello and welcome to the World Extreme Medicine Podcast. I am Stephen P. Wood, your host for today's session. I'm a critical care and emergency medicine nurse practitioner and World Extreme Medicine fellow, and I'm very excited to have you joining us today. I'm delighted today to be hosting Alan Lewis. Alan is an adjunct professor for Columbia Southern University and an associate consultant with Emergency Services Consulting International. He's joining me today to discuss a very important component of disaster response and humanitarian response, and that is cultural competency when working in developing countries. So welcome, Alan. It's great to have you on today.
Well, thank you, Stephen, and a big thank you to World Extreme Medicine. I've had a great experience presenting at the conference last year and discussing with the great attendees there. So I look forward to this conversation, and I think it's a very important conversation that few people are prepared for when they go into the world of humanitarian operations and international type of work. And so I'm looking forward.
Yeah, I would agree. I think we spend a lot of time, especially as medical providers, thinking about some of the disease processes that we might see. We think about what medications or equipment to bring. I've had a lot of discussions with guests about safety, about planning communication networks. But one thing I think that, gets left off a lot of checklists for, responding to humanitarian aid or being in a disaster response or even just traveling to another country is really thinking about cultural competency in these, areas. And that's what we'll talk about today. So tell me a little bit about your background and your interest in this area, this field.
Well, it really came about that I stumbled onto it. My first really international kind of deployment was kind of by accident with a non-governmental organization when I was visiting a friend in Belize and found out, that there was a team being put together to go to the disaster-ravaged area of Honduras, which had just been hit by Hurricane Mitch. And so I'm dating myself a bit here, but, this was 1998, and we just kind of, fell into it where they said, hey, we're putting a team together. Do you want to go? And I was in the middle of my paramedic training at that time. And I said, sure, why not? So about 3 weeks was spent in a city outside of Tegucigalpa known as El Progreso, which is kind of between San Pedro Sula and the north part of that region there. And I really got my eyes opened, I guess, at that time as, a pretty young 21-year-old kid, so to speak. Never really traveled outside the U.S., if you don't count Canada. It really opened my eyes to the needs of a population and just how little they had in terms of, not just food and medicine, but availability of resilience, to basically lack of infrastructure. And it really made me appreciate, what we have in the U.S. and what we take for granted many times with, 911 being universal. And there is no 911.
Yeah, for one, I congratulate you for taking your time outside of Belize. That sounded like it was a nice place to be, but that's obviously. Those of us who work in emergency medicine and who work in disaster medicine, we're ready to respond regardless of where we are. But that experience was kind of your first experience working with a population outside of the norm that you knew, which was the United States and all the infrastructure and resources we have. I think even in some of the poorest areas of the United States, the access to healthcare is just so much beyond what you might see in other countries. What were some of the lessons that you learned at that early age as a young, training paramedic uh, in your first disaster? What were some of the things that really drove home those points and made this an area of your interest?
Well, one, you better be, as we call it, super Gumby. You better be adaptable and uh, just very open to doing things in a different way and finding, non normal ways of doing things. For example, we witnessed or we came upon a person that was struck as a pedestrian by a vehicle. And as we were coming up onto that scene, there was a bunch of us in the vehicle. There was a pickup truck that pulled out, and two people got out dressed in kind of a Red Cross type of, kind of a visibility jacket or whatever. Picked up the person off the ground by the arms and legs, hauled him into the back of the pickup truck, then both proceeded to jump back in the cab of the pickup truck and drive off. That was their version of 911 and an ambulance. And it just kind of taught me right there that, wow, don't take anything for granted. I mean, not to mention, the C-spine precautions were thrown to the wind. The guy was not doing very good to begin with. It just made me realize that, there are such a lack of capability and standardization of care throughout the world. And I guess he's lucky that he even had anybody come pick him up, because in many parts of the world, you don't, or you have to pay ahead of time before that happens. So the just being, kind of getting your eyes open to different ways of, countries and cultures and what their expected normal is, was probably the biggest. And just the lack of prenatal care was one thing that we saw in especially the villagers that had a lot of their belongings and completely their homes destroyed. So there was lack of pre-hospital care, lack of prenatal care, for very, very common and easy to fix, GP type of things that, had an ounce of prevention would have definitely been worth a pound of cure. But we just saw a lot of exacerbated problems due to non-clean, no clean drinking water and lack of a sanitation system. And if you could fix the drinking water problem, clean drinking water, and the sanitation, that would take care of a very large number of your, disease processes. And I know that's not new to any of our listeners, but it was really, really impressed upon me because, in paramedic school, they don't really talk about, those type of issues that arise from, drinking water and sanitation, or the lack thereof. It's a focus on, a lot of trauma, a lot of cardiac, a lot of respiratory. But in the developing world, there is a very, very different focus. Yes, they still have the trauma and they still have, the medical concerns. But again, the root cause of a lot of this could be fixed with clean drinking water and good sanitation systems. And then sometimes, which is getting better now, but some, childhood immunizations.
No, I agree, and my background is in paramedicine as well, and certainly there really wasn't much with regard to public health measures, and I think that's a really growing piece to what how EMS can contribute to our healthcare system and to others, which is having some engagement in those public health concerns and really learning about these very simple things that make a significant impact. One of the things I wanted to ask you about, because we throw the term cultural competency around a bit, and we'll kind of get to that definition here in a little bit. But even in our own system, I work now in an intensive care unit. We're always somewhat critical when we get transfers from that famous outside hospital about certain things that were done, certain procedures or diagnoses, things of that nature, just in our own system. How important do you think it is to temper these kind of criticisms when you're an American or Canadian or someone from a developed country traveling to an area that's resource poor, and seeing things like you saw, like the kind of load and go with a trauma victim, where we might place a C collar, put them on a backboard back in the day, or at least some oxygen and potentially IVXs. How important is it to temper criticisms, and what are some of the things that that you feel we as providers can do to help us adapt to those different clinical scenarios?
Well, that's a good question because I think the first thing that a provider should do when going into another country, another developing country, especially, is seek to learn as much as you can beforehand about the system. Now, I didn't have much time in Honduras. I had a little bit more time when I went to Sudan, and we can talk about that later. But still, the information that you get outside of your area of operation may be very, very different than what the practicality, boots on the ground, actual operations are like. By that, I mean what you actually encounter may be very different than what is reported. Understand the system and the constraints that they're in. For example, in Honduras, uh, there is no nationalized system of any kind of standardization of care. There is no QA. There is no QI. There just isn't the checks that we have for quality in the developed countries. So understand that the system you're going into is resource poor, but that doesn't denigrate the willingness and the dedication of the providers that are there. There are some very, very good, kind-hearted people that are doing the best they can with the resources they have, and would love to have just a bit more resources, a bit more training. One thing that I have noticed is every country that I've ever been to in the developing world, when training has been offered, they have eagerly taken it up. It's never been turned down. So there's really a hunger for that. So I would say that when providers go into these countries, understand the system that you're going into, and don't use the standard that you're used to, and have a developed country kind of centric approach to it. Your system in the U.S. or Canada or Australia or UK will not work in these systems with the constraints that they currently have. You're taking what you view as perfect or much better in your world, which just will not work in the way that the current system is set up. So understand, what they're working with, and seek to be relatable to the providers. Again, it comes to that famous saying: people don't care how much you know until they know how much you care. So make sure that you're able to establish a commonality and really assist where you can. The criticism does no good. Believe me, they would be doing better, and they would be using sea collars if they had any money to afford them. They'd be using the spine board, in the indicated situations if they had the appropriate training. It isn't for lack of want, or it isn't for lack of desire. It's for the lack of resources being filled that a lot of these providers suffer from. So understand that, and I would save any criticisms for probably targeted at officials that hold money to disperse to those resources, and really try to work with them to show to build capacity through funding of these resources. And sometimes you can do that with government ministers and officials as involve them in the training, and if they can see the importance and the value of it, and be seen as a champion for that, you can really develop somebody that otherwise wasn't engaged into somebody who's a really big advocate.
Think that's an important take home point, and you also speak to, and maybe you can speak more to this, that training goes both ways, because I think when we deploy somewhere, that oftentimes you really need to speak to the local providers and get an understanding of some of the local traditions, or the way that certain disease processes or trauma is managed from those local providers. You might be able to enhance some of that, and provide some additional education or training. Do you have any experience with that, and can you speak to how important it is maybe to work with the locals and learn from them as well?
Oh, absolutely. So I'll use Guatemala City as a great example of that. I've developed a very good relationship with Fire Chief Cordon, of the Guatemala City Fire Department, the Volunteeros Bomberos. And one of the things that the department there has done under the leadership of one of their paramedics has developed a system that involves the usage of life packs. Well, these are life pack 12s that the batteries have basically went out on. I have seen some of the most ingenious wiring for taking a battery pack of AA batteries and taking out the old life pack 12 batteries and remodding it so that all they have to do is put rechargeable batteries in, and it runs the life pack 12 complete with defibrillation and everything. It is the most non-standard setup you have ever seen. I scratched my head when I saw it, but I've seen it work in action. The reason for that is they can't afford the several $100s that LifePak batteries cost. So they came up when those batteries died. They took the guts out of the inside of those LifePak 12 batteries and they remodded them and they made it work. And they did the same with the ventilator, with the suction equipment. I have seen the most jury rigged equipment that works, but I really have to give them a tip of the hat to making the best of some very, very difficult situation. It's either that or you don't have a functioning suction or you don't have a functioning LifePak 12. So understand the limitations of the people that you're working with, and reward that ingenuity with praise, because otherwise they wouldn't even be in operation. And then seek to enhance the training that they have and the equipment that they have. That would be my takeaways from that. And then it's just the relatability of just understanding where they're coming from and how difficult. I mean, I have accounts of individuals that are literally using their own money to buy personal protective equipment, especially during the pandemic, where departments couldn't provide that, or didn't have the funding to. And so, out of their own pockets, providing, things, even medicines. I've seen that as well. And most of us would just, be absolutely appalled that, that was having to be the case, but it was either that or there wouldn't be that level of treatment.
Yeah, I think especially you talked about personal protective equipment. We faced those concerns here in the United States with COVID, but I don't think we truly appreciated the impact that this had on less developed countries who had even less access to even basic masks, to gloves, to those types of equipment. So yeah, the ingenuity has always impressed me when I've seen people who come up with ingenious ways to tackle complex issues in resource poor areas. It's really we think we're smart when we're doing some of these things, but it's just amazing to see some of the ingenuity that can come from need. And that's a great story about the defibrillators. I'm not sure physio is necessarily psyched about that, but it's a necessity, and it just shows you what people can do when there's the need. You mentioned Sudan. Could you tell us a little bit about your experience there and some of the lessons learned from that experience?
Yeah, so in 2001, I was just brand new as a paramedic, for the most part, and took a position with a non-governmental organization known as Samaritan's Purse. And it was a logistician slash paramedic position there, and the paramedic was kind of the added on benefit. But it was myself and another doctor over there that was from the U.S., and we primarily treated the demobilized child soldiers. There were 1,700 demobilized child soldiers that had come into, or that had laid down their weapons after an agreement that the UN had brokered between the Sudan People's Liberation Army, or SPLA, and the GOS, or Government of Sudan. And remember, this is 2001, and so there was still an active conflict between the North and the South. There was no South Sudan at this point, although I was geographically located about 15 kilometers outside of Rumbek in a little town called Malengagok. And my role there was, well, it evolved over time to handle camp finances, but a lot of it was focused around getting in the weekly flights, coordinating those out of Lokachogio, which was our jump-off point out of Kenya. But these 1,700 kids were divided up into 5 camps, and one of these camps was one that I was primarily at. Had just about 350 boys. And when I say boys, I'm talking from 5 years old on up to 18. And these were kids that had, a lot of them had seen active conflict. Um, their parents had been killed. Almost every single one was a complete orphan, or their parents had been taken into captivity, i.e., most of the time their fathers had been killed after a raid on the village, and then their sisters, their mothers had been taken in the active slave trade. The government of Sudan troops had a pretty active slave trade that they were kidnapping the women and children from these villages and running them up on the train line through Wow, then into Egypt, and then they would be sold off into Saudi Arabia. And this continued for years and years. And in fact, the slave trade's still active. For those that don't know, human trafficking is very, very much alive and well in sub-Saharan Africa on up to the some of the countries that are in the Middle East, especially, seem to be big users of the slave trade. So these boys had really nowhere to go other than the Sudan People's Liberation Army. I mean, where does a kid go that needs food and that has had a family literally wiped out? And when I say wiped out, I mean these were Antonov aircraft that would roll in, drop 500-pound barrel bombs, kind of what we've seen in Syria, and the same type of things. Bomb the villages. Then the Janjaweed militias would sweep through. So the horseback mounted terrorists would basically just sweep through and kill everybody that was moving. One boy that I had, I'll never forget, hid in a well and grasped onto the side of a well that he'd climbed into. And for over 6 hours, he held onto the side of that, until the troops were gone, and was pulled out of it, and then joined the military because there was really nothing else for him to do. He had no relatives. He had to eat. A lot of these boys hauled firewood. They hauled wood for the camp. They were basically kind of, servants there in the camp. The older boys, I would say right around the 13, 14, many of them were on the front line, manning weapons, had seen active combat, had been through some pretty horrible things. It's just adding to the trauma of, already seeing your parents killed, your village annihilated, your livestock destroyed. And for those that don't understand, so livestock is a primary means of wealth. It's a primary means of sustenance. The Dinka was the tribe that I was primarily working with. These boys were all from the Dinka tribe. And it was really, really a blow to them economically and culturally to wipe out the cattle or to run them off in the way that these Janjaweed militias did. They really took everything from them. And we had these boys. We had them into schools, organized into. We had teachers that were local Sudanese teachers that were brought in. This was all organized under Operation Lifeline Sudan, or OLS. And these NGOs like Samaritan's Purse were given these camps to take care of. But one of the things that became so important was relatability. And I was just talking to somebody the other day about this. Is that my background as a farm kid, I knew a bit about animal husbandry. And so to talk to them about cattle was huge in their, kind of broken English. And we had English classes for them as well in the several months that I was there. And so we could communicate. And there were some that were actually very, very good at communicating in English. But just establishing that rapport. Remember, these are kids that literally didn't know anything about germs, didn't know anything about, sanitation, even simple things like washing your hands. So we saw a lot of things like bilharzia, guinea worm. There was even some cases of TB. So there was a lot of, the medical that went with it. But the most important thing was the ability to be able to relate to these kids. And really, they were very, very curious. They wanted to learn English. They all, had great dreams, engineers and doctors. And one of the kids, it was great to find out just it's been a few years ago now, but did actually make it to Australia and is living there. There's been some success stories that have come out of that camp. But yeah, very, very interesting experience for these young boys to go through that. And I definitely learned a lot as far as relatability and just kind of the universal kind of aims, desires, and goals of people. And it was it was definitely a life changing experience.
Like a life changing experience for sure. And yeah, thank you for your work there. And it is an eye opening experience to hear about these young boys that have seen active military confrontation at the age of 5, 6, 10, 13, whatever it may be. And it's just we have so many issues that we think about and worry about, and we tend to kind of centralize those issues and think about what's important to us, and just hearing these stories and knowing what other people have to go through to survive. It's very eye opening, and it's critically important for people to hear these stories. So thank you so much for sharing that. I do want to take a little bit of a segue. We have a fairly diverse audience here at World Extreme Medicine, and plenty of paramedics, both in the United States, but also the UK, Australia, Canada, and abroad. Paramedicine has, as you mentioned, focused a lot on kind of working in a local system, and we kind of touched on that. It'd be interesting to see, paramedic education have a little bit broader introduction to some of these, global health and public health issues. I think, and you can tell me what your thoughts are, but paramedics are sometimes kind of forgotten when it comes to disaster response or work in humanitarian areas. I mean, I think, and I'm not sure if it's still the case, but Doctors Without Borders didn't recognize paramedics as being part of the healthcare team. You had to be a doctor or a nurse to deploy with them. I don't know if that's changed, and if it has, that's great. What are your thoughts on on paramedicine and paramedics getting involved in humanitarian aid, and if what would your advice be for those of our audience who are in the field of EMS and who are paramedics or EMTs?
I think it's a developing field, and it should be encouraged. I'm encouraged by some of the formalized education I see, being promoted by World Extreme Medicine, and the diplomas being offered in remote medicine, and some of these advanced courses that they're taking. I would really like to see it looked at and established as a professional discipline in an accepted way among other allied healthcare professionals. I think we do a great disservice when we overlook paramedics and focus on, just doctors and just nurses. Now, they definitely have a role, and they definitely have a place. And I was very thankful for the doctor that was with me, because otherwise it would have been me and a PDR, physician's desk reference, trying to figure out, this shipment of medications and how to use it. That's not the ideal way. I mean, how many paramedics have prescribed mebendazole? That's just not something that you find in your protocols when you're a street paramedic in the USA. I remember when I got back, the nurse in my paramedic program, this was in Honduras, looked at me and she said, "You were prescribing medicine?" I said, "Well, yeah, we had medicine and we had to give it out. We had worming, I was doing antibiotics as well, regiments, just because of the infections that we were seeing in Honduras." And she said, "Well, who was your supervising physician and who authorized that?" And I said, "It's Honduras. There was none." And, do you put yourself at liability? Absolutely. But, considering the circumstances, I mean, who's going to sue you, and what kind of oversight is there really? It was the same in Afghanistan. The first time I went, I remember getting the Ranger handbook thrown at me. Said, "Here's your protocols," and they were all offline protocols. Yeah, there was a doctor somewhere, but it was not a direct medical control. So it isn't fair to set up paramedics without training and without experience into a role that they're not ready to assume. And a trial by fire can be very dangerous for both the paramedic and the patient as well. But I will say that the risk of not doing anything far outweighs the risk of doing something wrong, especially if you have a competent paramedic and one that utilizes other, allied healthcare professionals, doctors, nurses that are in the area. So I think it definitely should be a team approach. Ideally, it would be nice to have a doctor for supervision, but let's face it, there's some places where there just aren't doctors, and doctors aren't going to go. And I think of some of the high threat missions that we did with the State Department in Iraq and Afghanistan, and yeah, you'll have some U.S. Embassy PAs or maybe even a doctor at the embassy compound itself, but they're not out there in the field. They're not flying on the helicopter with us. So you have to really train and develop. And am biased, of course, being a paramedic, but I really like the ability of paramedics to be problem solvers, especially if those paramedics are cross-trained in fire and rescue services. I mean, that's what we do. We fix things. We crawl into upside-down cars. We respond to flooding. We respond to fires. We make things work. And so there's a mindset of never knowing what you're going to get. Whereas I think sometimes in our other, brothers and sisters in allied health professions that are, in a clean and sterile environment, whether it's an A&E or an ER, where the patient's brought to them and, somebody's scribing and, everything is ordered and neat. And sometimes our brothers and sisters in the allied health care professionals don't do well if they haven't been prepared adequately for operating in a very non-permissive environment or one in which you just don't have the resources. They'll look around for a nurse to carry out an order that they're going to give and then realize there is no other nurse. It's you. You have to do exactly that, and whether it's wound debridement or, writing a script and then filling that script yourself, there definitely is you're wearing a lot of hats, and you're having to do a lot of things that you may, have had others to assist you with. And sometimes that means utilizing the local workforce or local, population that may have only a very basic first aid understanding. Here, press here, hold this wound here, open the airway this way. I've done that in numerous different circumstances and even in trained others. And I think that's an important part of this too, is that we need to train the people where we go to be force multipliers, in that they can care for other people after we're gone. Because we can be in a place for a week or 2 weeks and carry out medical care, but what happens when we're gone? And I think that capacity building has many times been overlooked in certain organizations where they just go in, they do a mission, they take care of things, but again, it falls back to that sanitation and lack of clean drinking water, and we were right back where we started. And you can just see that by monitoring the cholera outbreaks that we have going on now and things like that. So
Yeah, those are very important points, and so one thing that I really love about World Extreme Medicine is the inclusivity. They truly recognize that we all need to work together, and I really a lot of these types of programs are geared towards physicians, nurses, and I'm myself am now a nurse practitioner, and I get to benefit from that. But they also include paramedics. They include physical therapy. Physical therapists can be one of the most important people in some settings, especially for the management of stroke and things of that nature. So World Extreme Medicine's done a wonderful job about inclusivity and opening the training to all, even to laypersons and non-medical folks. So that's one piece. But I also wanted to build on what you were talking about. It can be certainly a fine line for kind of acting or working within your scope of practice. And I think a lot of people think that, well, if I'm going to Haiti or I'm going to Sudan or I'm going to another developed country, I can operate well beyond my scope of practice. Certainly there's, as you mentioned, there's a fine line. What would your advice be to people, and what are your thoughts on kind of this scope of practice idea, and working outside of our scope of practice in certain settings?
Yeah, I would say that's you have to choose the right type of individual to go. You can't choose somebody who is gung ho to the point where they think that the developing country is a chance to try out every new skill that they've ever seen illustrated or depicted on YouTube. I you have to be very very careful that you have a maturity both mentally and emotionally with the people that are chosen to go on a deployment or on a team with you. And oversight is important. And when that we especially for the first timers, I would say it's very very important that there is a doctor or a higher level medical provider overseeing a person, and that would be the ideal situation where you would be part of a team, you would deploy, you would have a set mission, there would be an existing structure. I didn't have that luxury when I went to Honduras the first time. It was a non-governmental organization. It was ad hoc. It was myself and another nurse, and fortunately, she could speak Spanish very very well, and we could bounce a lot of stuff off of each other. And you find in some of those situations when you have other healthcare providers, they're very very good. And she was very very good at say the medications and what was appropriate in diagnosing. Especially being a female, she was very, very easy to talk and with the other female patients about things that would be culturally very reticent to talk with a male about. Everything from PID to pregnancies to STDs and things like that, and they would be much much less prone to give a full accounting of those symptoms to a male provider. And that goes back to understanding the culture of the environment that you're operating in and understanding that, as a male, you're not the best person to have that conversation, and you play a more supporting role. Yet when there's a trauma or something like that, that's where you may have the male paramedic that is very, very good. That's their skill set. So I think that's definitely an important part of it. Yeah, that you really some people can get themselves into trouble, and I know there's been at least a couple instances where I've seen people attempt to act beyond their scope, and they were quickly reined in by myself and others that just were like, you can't do that. You're only certified to this level, and you're trying to give out a narcotic, and no, that's just not happening. So there does need to be a system of checks and balances, especially for your newer members that are out there in the field. And yeah, that could be I could actually have a whole nother podcast on on that topic probably.
Yeah, that's important. Those are important issues, and I appreciate your kind of thoughtful response to that, because it is we do see people thinking that this is an opportunity of medical tourism to practice things that are beyond their scope, and we really still need to be respectful of your training and know that these people are deserving of the best care, and if something beyond your scope, that you know it's best left to those people who have experience with those, be it a procedure or medication. So thank you for that thoughtful response. You also mentioned capacity building and the importance of that. I think again, you mentioned that a lot of times, teams will come in, set up, be there for a week, maybe 2 weeks, providing care, and then leaving. What has been your experience with capacity building, and do you have any advice to our listeners on how to integrate that into their medical plans for when they're deploying?
So and this is one of the things that I think probably frustrated me the most in Sudan was just, and well, a bit in Honduras too, but I didn't understand it as fully then. But it was very very frustrating to think, okay, we're here for 3 months in Sudan, and then we leave, and then what? What's going to change? There's still okay. There's a well here that's been established, so that's good. They have clean drinking water. Good for the UN, the water program on that. But the sanitation issue really hasn't changed. There is no continuing casualty field hospital or care facility. There's no supply of medications. There's no medical doctor or provider going to be present. And so, what's to prevent this from looking exactly the way it did before we came within a year or two? And I just saw a lot of really well-meaning organizations go in and create a lot of light, like a flash in the pan, um, with an address of an immediate problem. And this happens at every single disaster that I've witnessed, and we're even seeing it in some cases with the Ukraine situation, where they will highlight a current cause, raise a lot of money off of it, and then there'll be an earthquake somewhere, and the first one will be forgotten about, and off we go again to the next one. And so it's kind of like halfway between whack-a-mole and spot fires, because it pops up here and they jump on this and then they're on to the next one, and there really isn't any long-term capacity building that will fix the situation to be better prepared for either the next disaster, whether that's a tsunami, an earthquake, in building in terms of maybe search and rescue teams, maybe more standardized housing construction in some places, flood control, in others. But what is being done to build the capacity of the responders in that area? And one of the things that I was fortunate to be able to do is go back to Honduras in 1999 and help teach an EMT class on the island of Guanaja. And that was to help build that emergency team's response for the next hurricane. Well, of course, they had another hurricane, a few years down the road, and they're a little bit better prepared because of that. But I see too many times where capacity building isn't really a thought of some of these organizations, and I think that we need to have a more thoughtful approach with whether it's USAID, State Department money, and I'm talking from the U.S. as to what we do to build resiliency, what we do to build capacities in these communities to prevent a disaster from happening, first of all, and then to pre-position, stores, supplies, and a roster of capable personnel that really function as kind of what the military uses, the mobile integrated training teams. Is so you go in, you partner with the local counterparts, and you train them, and you give them direct advice on how to set up their emergency response system, and that may involve communications, that may involve vehicles, that may involve leadership training, that may involve what are they really lacking. But in order to do that, you have to conduct an assessment of what the needs are and really get their buy-in and really formulate what your end goal is as far as preparedness, and then bring in people that can relate to them competently in their culture and that they trust, and then build that capacity. Because I see too many times where it is just gone in and we solve the immediate problem, or so we think, but then when we leave, there's this vacuum that kind of exists, and then things just kind of it's like the sand in the beach, when the water comes in, you might have made it an impression or a hole, but it all just fills back in when that resource is gone. We want to be careful that we don't replace the need for local resources by supplementing it to a point where they become dependent upon that need, and we stay away from we swoop in and solve all your problems, and then the population becomes dependent on that for that short time period. But then when we leave as an organization, nothing has been gained, and there isn't anybody that can train other people to deliver care, whether it's first aiders or first responders, and that type of training, and the capacity of the hospitals themselves haven't increased. I've seen donations of X-ray and MRI equipment and beautiful hospitals that were built and literally don't have any capacity because the government and the funding organization of that country did not work together to ensure that facility was going to be staffed. So brand new medical equipment still sitting in its plastic wrap in the corner, not able to be used because there wasn't a thoughtful deployment process or capacity building in that country.
Yeah, those are incredibly important points, and building that resilience, taking an all hazards planning approach, training local individuals, and really thinking about what's the greatest need for that particular area, and how do we, best, train these individuals or provide for these individuals. Like you said, you can buy a beautiful CT scan. If you don't have a CT technologist or even nursing, to staff those hospitals, then the system's going to fail. And I think we take a very kind of centric approach, not just necessarily U.S. centric, but developed country centric approach to trying to solve these problems. When, like you said, it oftentimes comes down to very, very basic principles like hygiene, sanitation, and some very basic care that is really going to provide a much greater resilience to that community. And so very, very important points. We're actually running up against our time, believe it or not. I think we could spend the rest of the day chatting on these topics, and hopefully we'll get to do that together at some point. But I did want to say it's been a delight to chat with you today. I hope that you're going to be joining us again in November in Edinburgh for the World Extreme Medicine Conference. Any plans for attending?
Not only attending, but I'm actually presenting. EMS
excellent. Great.
Yeah, I'm presenting on EMS leadership lessons learned from the Arctic to South Sudan. So it'll talk a lot about the cultural competency that we were talking about today. I'll talk a little bit about the Congo. We didn't talk about the Congo. We didn't talk about Afghanistan or Iraq at all. And those were interesting times, to be sure. But I really appreciate the conversation, and I would encourage anybody that's interested in becoming involved in humanitarian medicine and working outside, outside their comfort zone and in developing countries. I'm happy to give advice. I wish I had known a lot of the things that I learned along the way before getting into this, but it's very hard to get into sometimes. I've learned that from people that have just said, well, I'm trying and I can't get in. And I always encourage people, join a non-governmental organization. It doesn't matter whether it's but just get some experience outside the country. It will build you. It will build you as a person, and it will build some things like your ability to communicate across cultural barriers, and that experience is invaluable.
Well, great, and that's a great teaser for those who want to learn more about this. Certainly attend your discussion at the World Extreme Medicine Conference in Edinburgh in November. I'll certainly be doing that as well. And we'll also have in the show notes some ways to get involved and some ways to contact you as well. Again, it's been a delight, a pleasure. These were incredibly important topics. Certainly, again, we could spend the rest of the day talking about each one of those topics, and I appreciate you taking the time, and I appreciate your thoughtful approach to all of these issues and sharing that information with us today.
Well, thank you very much. I've enjoyed the chat, and I've had a lot of very good mentors and friends along the way that have helped me, and so I just want to do that for other people that would like to get involved in a calling like this. So thank you very much.
Well, thank you, Alan, and thank you to all of our listeners for joining us today.
If you've enjoyed this episode of the World Extreme Medicine podcast, please subscribe, like, and share. And if you want to meet lots of other risk-taking, rule-bending, and inspirational people, then you need to be in Edinburgh on the 19th to the 21st of November for this year's conference. Tickets are on sale now. Go to extrememedicineexpo.com to find out more.